Welcome to Dental Board Reviews. Today we're going to discuss the current update on bisphosphonates. Okay, these are the current updates on bisphosphonates, which were released in 2022. Okay, so you must know this. And if you haven't subscribed, go ahead and subscribe so you can receive notification for the new reviews. Okay. So, what is the mechanism of action of bisphosphonate? So, they inhibit osteoblastic bone resorption and remodeling, or B, inhibition of osteoclastic bone resorption, or C, rank ligand inhibitors, or all the above. All right? So, you must know that bisphosphonates, they inhibit osteoclastic bone resorption and remodeling. Okay? This is what they do. All right? So, our answer here is B. Which of the following condition is bisphosphonate therapy indicated? A, multiple myeloma. B, osteoporosis. C, Paget disease of bone. D, malignancy metastatic to bone. Hypercalcemia of malignancy. F, or the above. Okay, so all these conditions are indications for bisphosphonates. Okay, so all these conditions can be treated, I wouldn't say treated, but managed with bisphosphonates. So our answer is F. So here's a question for you. Mr. Jones presents to your clinic with a complaint of pain on tooth number 3 as the upper right first molar. Your assessment shows that tooth number 3 is non-restorable and will need extraction. You remember that Mr. Jones has been taking Fosamax for 5 years. What is the appropriate management of Mr. Jones? Okay. So is it A, extract tooth without any modifications? Or B, consult Mr. Jones' physician and ask to stop Fosamax for 2 to 3 months before the extraction and 3 months after the extraction? Or stop Fosamax for 1 day and then do the extraction? Or D, or the above? Correct. So, this is where it gets interesting, all right? In the previous recommendations, which were in 2014, now these recommendations are 2022 recommendations. In previous recommendations, 2014, our answer would have been B. Okay? You need to consult Mr. Jones' physician as to stop Fosamax 2 to 3 months before the extraction and 3 months after the extraction. So, however, this information has been updated. Okay? So the new recommendations say that a drug holiday, such as in the answer of B, is very controversial. However, Fosamax, okay, Fosamax here is an oral bisphosphonate. And usually these oral bisphosphonates has a very low risk, very, very low. Okay, I think it's less than 0.01% of developing MRONJ. So, because drug holidays have been deemed controversial, what you have to assess the patient if they are taking this for for osteoporosis, and they don't have any other comorbidities such as uncontrolled diabetes, okay, or they're not receiving any other chemotherapy, then you don't need to modify anything. So our answer would be A. Okay. Now, if Mr. Jones comes in and they have this long history of uncontrolled disorders, or they're immunocompromised, then B will be appropriate. So the new recommendations, they leave it up to the clinician, okay, to assess the patient and assess the risk of developing MRONJ. But if it's just Fosamax and the patient is otherwise healthy, meaning doesn't have any immunocompromise, or they're not, they don't have any uncontrolled diabetes or any other medical conditions that decrease the immune system function, then A is appropriate. So you can extract without any modifications. Okay. So you have to know this. Okay, and review them really well. Okay. So our answer here, if you follow the 2014 guidelines, this will be the answer. Okay. So most likely, if you're taking your exam, INBDE exam, okay, if the questions were constructed before these recommendations, most likely your answer will be B. Now, you can always consult the physician, that's fine, and ask to see if you can stop. Now, the physician sometimes will tell you, okay, no, we cannot stop it. So if we cannot stop it, then you can discuss. Now, you have to discuss with the patient the risk of MRONJ, whether you deem it to be a small risk in percentage. Okay, you still have to discuss those risks. Okay, all right. Which of the following is a bisphosphonate? Alendronate, that's A, alendronate, B, pamindronate, C, zelondronate, or D, or the above. So, alendronate is Fosamax, pamindronate, and zelondronate. So, all these are bisphosphonates. Okay, so all these are bisphosphonates. Okay. Now, let's review the updates. Okay, so these were updated by American Association of Rheumatoid Surgery. Okay, and it's on diagnosis and treatment of MRONJ, medication-related osteonecrosis of the jaw. Okay, and this is based on the available research data. Okay. Okay. So in the updates, number one, dentists must communicate the risk of MRONJ to both patients and other providers such as physicians. So it really, sometimes there's some physicians who haven't really paid attention to MRONJ because they don't work in the mouth. So they may not know the consequences of prescribing bisphosphonates, okay, in the oral cavity. So sometimes when they come at you, you have to write to the physician and say, hey, patient's about to start this medication, there's a risk of this, and so you can provide recommendations of go ahead and take care of any dental treatments such as extractions prior to starting these medications. Okay, so you have to educate. Really, don't assume that physicians know. Okay, so always you have to. When I say educate, with humility, of course. Okay, so dentists must communicate risk of MRONJ to patients and other providers. So bisphosphonates have a significant positive effect on quality of life in patients with cancer involving metastatic to the bone, okay, and they reduce fractures. So this is the benefit of bisphosphonates. So you wonder, why are all these medications being given when they have the risk of MRONJ? Remember, MRONJ is a smaller risk, okay, compared to the risk of fractures, such as if the back fractures, okay, the spine fractures, or you have a femur fracture. Those can be very deadly, okay, and debilitating. And so I say they can improve the quality of life by reducing the risk of fracture. So bisphosphonates are used in fragile bone conditions to reduce the risk of fracture, okay? So osteoporosis or osteopenia. There are other conditions, as we mentioned before in the previous slide. And bisphosphonate can also be used in metabolic diseases such as Paget's diseases and osteogenesis imperfecta. Okay, so in which condition have bisphosphonate therapy has not demonstrated efficacy? Okay, so osteoporosis or fibrous dysplasia or osteogenesis imperfecta or multiple myeloma. Okay, so according to AAOMS 2022 update on MRONJ, clinical trials have not demonstrated efficacy of bisphosphonate therapy in management of fibrous dysplasia. Okay, so remember that. So there's no efficacy of bisphosphonate. Okay, we're talking about bisphosphonate. There's no efficacy of bisphosphonate in management of fibrous dysplasia. Now, oral bisphosphonates. So oral bisphosphonates, an example of oral bisphosphonates that are so Fosamax. You have to know Fosamax, which alendronate, or Actenol, okay, which is Risedronate. And then you have parenteral bisphosphonates, which are either given IV or IM, okay, or subcutaneously or IV. And these bisphosphonates include Reclast, which is Zolendronate, or Boniva, okay, Ibandronate, okay. So make sure you know this type of medications, so when you see them, you know how to take care of the patient. Now, let's pay attention here. So what is denosumab? Okay, denosumab. So when you see AB, okay, in some of these names, just know that it is not really a bisphosphonate. It may help with bone, okay. It may help to reduce bone resorption. It can help to produce more bone. But when you ever see MAB in the name, it means it's some kind of antibody, okay? Antibody against a specific ligand, okay, or specific protein in the body, okay? So just remember that. So denosumab is a receptor activator of nuclear factor kappa B, so rank L inhibitor. Remember, nuclear factor kappa B, what it does in the cell is it goes in the cell, attaches to areas of the RNA and DNA, and induces protein synthesis. Okay. So denosumab, it is an anti-resorptive agent for bones. Okay? And it is sold as a fully humanized antibody against rank ligand. Okay? Remember, it inhibits rank ligand. What is the mechanism of action of denosumab? So denosumab is a humanized antibody against rank ligand, and therefore it inhibits osteoclast function and inhibits bone resorption. Okay? It inhibits osteoclast function and inhibits bone resorption. Okay? It binds rank L. So it binds rank ligand. That's what denosumab does. So example of denosumab brand names are, we have Prolia. So Prolia is administered every 6 months subcutaneously, okay, for osteoporosis. And Exgiva. Exgiva is administered monthly for metastatic bone disease from solid tumors. Okay, so you have to know how these medications are given, so you can have an appropriate window for treatment. Okay, when the patient is taking these medications. So, which conditions have rank L inhibitors therapy demonstrated efficacy? So, in which condition have rank L inhibitors such as denosumab shown efficacy? Okay, so is it osteoporosis, fibrous dysplasia, germ cell tumors, osteogenesis imperfecta, or multiple myeloma? So, according to AOMS 2022 update on MRONJ, so rank ligand inhibitors have proven efficacy in treatment of giant cell tumors of bone and fibrous dysplasia. Okay. What is one of the differences between bisphosphonate and denosumab? That's rank L inhibitor. So what is one of the differences? So bisphosphonates bind to bone, and denosumab, which is a rank L inhibitor, does not bind to bone. So because denosumab does not bind to bone, it has a shorter life, okay, half-life. So as I say, you have to know how Prolia and Exgiva are given. Prolia is given every 6 months. If so, the patient has taken it, the shot, what we call the shot, the injection subcutaneously. For example, it's been 4 months, or it's been 3 months, or 5 months. That means you can safely treat the patient, okay, because the denosumab has a shorter half-life when compared to bisphosphonate. So effects of denosumab on bone resorption are diminished within the 6 months of stopping denosumab. So if somebody has taken it and is getting close to 6 months, okay, that means most of that denosumab is really being eliminated out of the body. Okay, so the risk of MRONJ, you never say zero, is diminished. Okay, so you can treat the patient after you discuss the risks of MRONJ, of course. Okay, so just remember that these are the differences between bisphosphonates and denosumab. Which of the following monoclonal antibody is not a rank L inhibitor? Is it Prolia, romosozumab or Xgeva. Okay? So romosozumab is not a rank L inhibitor. So Prolia and Xgeva, those are rank L inhibitors. Okay, so those are brand names of denosumab. But romosozumab is not a rank L inhibitor. So, which of the following is not a bisphosphonate? Zelondronate, alendronate, romosozumab, denosumab. Okay, so here you have to know that, as I said, when you see the ab at the end of the name, just know that it's not a bisphosphonate. Okay? And so, but remember, they can also give you brand names. So you also have to appreciate brand names and know the brand names. So romosozumab is not a bisphosphonate. Denosumab is also not a bisphosphonate. So here and in our list, romosozumab and denosumab are not bisphosphonate. Okay? Which bone anti-resorptive medication works in the WNT pathway? Okay, is it Xgeva, Prolia, Fosamax, or romosozumab? So our answer here is going to be romosozumab. Romosozumab does not work in the rank L pathway. Okay, it does not. It's not a rank L inhibitor, and it's not a bisphosphonate. So it works in the WNT pathway. So this is one of the new agents. Which of the following binds sclerostin? So romosozumab, alendronate, Boniva, or Xgeva. So the one which binds sclerostin is romosozumab. Okay, romosozumab is not a rank L ligand, so it's not the same as denosumab. It's not the same as the other bisphosphonates, so it's not a bisphosphonate. So this is a WNT pathway inhibitor, which is an inhibitor of sclerostin. Okay, so it's an inhibitor of sclerostin in the WNT pathway, WNT pathway. So what is romosozumab? Let's look at it. So it is a new monoclonal antibody used in osteoporosis to prevent bone fractures. It is administered subcutaneously, just like Prolia and Xgeva, and it binds sclerostin, it inhibits sclerostin, and therefore increases bone formation and decreases bone resorption. So here, excuse my slide here, this is supposed to be, let me change it here, let's see, I can use a, so it decreases bone resorption. Okay, so it decreases bone resorption.